Good afternoon, good morning, I mean.
Yeah, good morning, good afternoon. Hang on. So, right. So I've just started recording the session. Good morning, good afternoon, good evening. This is DOW 2002 CPD Webinar series. This is an initiative taken by us for the benefit of all of us. And these webinars are going to be held once a month, every first Sunday of each month. So the next webinar is going to be on the 3rd of March, and it is going to be on topics related to cardiology. Some rules. So when the speaker is speaking, please all mute your microphones so there is no background noise. There's going to be 2 presentations in these webinar series. So we start at 11, and then first speaker talks for about 20 minutes, and then the second speaker starts another 20 minutes, and in the last 15-20 minutes we take question and answers. So unless it's a really burning question, we take questions in the end. So I think and then we also provide certificates to all the participants. So if you could email me, please, your full name, and then we'll issue you certificates. Just send me an email at naseem@naqvi@me.com. I'm going to type it. Those of you who don't have my email, just drop me an email on this address. It's in the chat box. There. So that's my email. Okay. So we have got 2 presenters today. And generally the topics are going to be very acute general medicine, general surgery for general physicians at registrar level, kind of senior SHO registrar level topics, because we decided not to keep it very specialized, because it will be then relevant to a very small sector of specialists. So we decided to keep it a bit broad and bit generic, so everybody benefits from it. So today we have 2 topics, acute abdomen and the management of acute abdomen in the emergency settings, how to evaluate a patient with abdominal pain. And the second topic is hypercalcemias and the management of hypercalcemia, and also a bit about thyroid emergencies. Fahad has very kindly agreed to give us talk to us for a few minutes about also some thyroid emergencies. So the first speaker today is Sadaf Jafar Boy. Sadaf is a post-CCT fellow in University of Manchester Foundation Trust, and Sadaf is going to talk about acute abdomen and the evaluation and urgent management of acute abdomen in the emergency settings. Very important topic. We see acute abdomen all the time. If you are working as a general physician or acute physician, even if you are a specialist on call, you will come across acute abdomen at least 2 or 3 times during your working week. And there are lots of different causes. Some are very serious, some are benign. So Sadaf is going to take us through this very important topic. Sadaf, over to you.
Thank you, Naseem, for the kind introduction. It's a huge topic to cover. As all of us know, surgical problems, surgical emergencies involve a variety of problems. So I'm going to talk about leaking aneurysms, ischemic gut, obstruction, perforation, and touch base on pancreatitis for a wee bit. So with acute surgical patient, like any other patient, you start with taking a thorough history and examination. And what you're interested to know is how long the symptoms have been, because that will guide you to your diagnosis. So if they've got pain or if they've got symptoms of vomiting, you need to know how long the symptoms have been going on. And you need to do all their bloods. So your blood test will involve a full blood count using Es, LFTs, renal functions, as like any other acute emergency patient would need. But we like, as all surgeons, to check on CRPs and amylase and anatol. This is a big criticism from A&E to say, well, we shouldn't do CRPs. But I'm going to talk to you a bit later as to what the importance of CRPs is. And gases are equally important. It doesn't mean that you have to do an arterial gas, but a venous gas, just to get a bit of an idea as to what the acid-base balance is doing and what the lactate is. Now, by default, anyone who thinks the patient has got a surgical problem gets a chest and an abdominal X-ray. Now, chest X-ray is not always necessary if you think the patient will need a CT scan irrespective. But if you think the patient has got perforation or you want to rule out any chest problems, yes, by all means, go ahead and do a chest X-ray. And do an abdominal X-ray only and only if you think the patient has got any problems related to obstruction. But if you think this is all perforation and nothing else, I haven't come across a single patient where I thought the patient has got perforation and an abdominal X-ray showed pneumoperitoneum where a chest X-ray did not. And then in the end, we all love to do CT scans, and that is the way forward. Not saying that we are going by the American way, but it is essential in this day and age that you get a CT scan so that you know what exactly you're dealing with. So I'll start off with abdominal aortic aneurysm. We all know that these patients are a bit of middle age group, and generally they have some cardiovascular comorbidities. And they present with sudden onset of pain. It doesn't necessarily need to be abdominal pain. It can be back pain, and it is usually quite severe, not something that is just resolved with a dose of paracetamol or a touch of codeine. They look really, really clammy. They look unwell. They are hypotensive and tachycardic when you see them, unless and until they are beta blocked. And they may have an altered sensorium just because they are markedly hypotensive and the cerebral perfusion can be impaired. And we know from lots of studies done in the past that a ruptured aneurysm has got a very high mortality, and 50% of the patients with a leaking aneurysm do not make it to the hospital. And of the ones who come in, 50% of them are not fit for a surgery. And out of the ones that we decide that they can go ahead and have surgery, 30% of them die after having had an operation. So essentially, time is the essence. What you can do in A&E, because you would be the first person seeing this patient. So it depends, particularly if you're working in the UK, you need to know whether there is an in-house vascular services or you have to refer the patient somewhere out of your own hospital. So in A&E, make sure you've got reasonable IV access to the patients. All the bloods have been sent off. And as A&E doctors, all of you should be able to fast scan the patient. And what you're interested to know is, can you see the aorta? If you can, how big is it? Because anything that's more than 5 centimeters, you start to worry about, is it leaking or is it not? And if you don't have any in-house vascular services, then you need to contact your regional vascular department and arrange for an emergency or a blue light transfer. Now, this is one case where you need to get an urgent CT and do it with contrast, because doing a CT scan without contrast is equal to not doing any scan at all. Because what you need to know is where is the aneurysm? What is the extent of it? Is it leaking? Is it not? And your further management will be dependent on what the radiologists find on the CT scan. And I've mentioned something called permissive hypotension, which is quite important if you're managing someone whom you suspect has got a leaking aneurysm. With permissive hypotension, you mean to say that you're allowing the blood pressure to be low enough, provided the cerebral perfusion is maintained. So the way to check on it would be to make sure the patient is still alert, oriented, and he can have a reasonable conversation. Because you can imagine if the cerebral perfusion gets impaired, then you know by default all the other organs will not be adequately perfused. So moving on to some scans where we know that on the left of the screen, you can see there is a nice aneurysm, and you can see some blood within the lumen of it. Whereas on the right of the screen, you can see there is lots of blood around the aorta. You cannot actually define the wall of the aorta. So if you see something like that, that should start ringing alarm bells to you. And by then I would expect that someone has already contacted the general surgeon or the vascular surgeon, depending on what services are available in your.
So just a quick question. So the hypodense area, the black area is the blood, or is the white area the blood?
So we are talking, do you mean to say the left or the right of the screen?
The left of the screen. There is an arrow pointing towards that. This is the white bit is the aneurysm, the dissection. Is that right?
So if you can see sort of on the Y, you can see a well-defined outline. You can see where the aneurysm is, and that is the wall of the aneurysm. What is within it? It's actually the contrast saying there is blood within it, but it's not leaked. The one on the left hasn't leaked, whereas the one on the right has leaked.
Thank you.
So again, if you happen to be in a setting where you've got in-house vascular services, by then make sure you've activated what is called the major hemorrhage protocol, where you get at least 4 units of packed cells, 4 units of FFPs, a couple of pool of platelets. So all you need to do is ring your blood bank and put the word, I need major hemorrhage protocol to be activated. You don't have to tell them individually what products you need. Make sure the anesthetist is en route and the emergency theater is well aware that there is someone with a leaking aneurysm in the emergency department who needs his way up to the ER, to the operating room. So time is essence, like I said, right at the outset. So you've done bloods, make sure you've got your scans available, you've done an ECG, you've catheterized the patient, because all this is the information the anesthetist would want to know. So make sure while all this is going on, you've bought that time to do what is necessary for the patient. That's all we expect to be done in the emergency setting, and you can leave the rest of the things for the surgical team to sort out. So moving on to ischemic gut. Now again, ischemic gut is a quite significant event. So anyone who presents with a dead gut has got a very short history. So someone who comes with 5 days of abdominal pain, you can surely say that this is not an acute ischemic gut unless and until he's had any surgical problem that has eventually led to bowel ischemia. So it's important that you elicit all the cardiovascular factors, make sure they haven't had any previous history of ischemic heart disease, they are not diabetic, they haven't had previous problems like strokes or TIAs. And interestingly, in these patients, their symptoms are disproportionate to the signs. So they would complain of a lot of pain, but when you examine them, you can't elicit any focal area of tenderness, and certainly there's no peritonism. And as I mentioned to you right at the start of the talk, do some gases. That will tell you, is the patient acidotic? Has he got high lactate in his blood or not? But mind you, when you do all the bloods, you send off an amylase as well, as you would do for anyone who's got abdominal pain, and the amylase can be elevated. Now, there's a degree of elevation which will tell you, is it pancreatitis, is it not pancreatitis? I'm going to touch base on that later on. But an amylase of something like 200, where the normal cutoff is 100, that would not tell you this is pancreatitis. And you start thinking, is there any other cause why this patient has got high amylase? And one of the causes can be an ischemic bowel. Now we know that the blood supply to the bowel can get affected because of various reasons. It can be arterial, it can be venous, it could be thrombotic or an embolic phenomena. And interestingly, the superior mesenteric artery is the most commonest vessel that can get affected. I'm not going to go into the details of the anatomy, but the way the SMA comes out of the aorta, that makes it more and more prone to develop any clot, whether it's a thrombotic or an embolic event. So if you got someone where you think that the patient has got an ischemic gut, make sure you give them appropriate analgesia. There's no point in patients suffering. And it's a very common myth that you come across. Oh, I didn't want to give the patient any morphine because that may have masked the findings. No, you don't want your patient to suffer. So if the patient requires anything like morphine, go for it. Give them oxygen. Make sure they are fluid resuscitated. And the fluid of choice would be heart mints. Don't give them saline because normal saline can increase acidosis. So don't give them normal saline, just give them heart mints. Give them IV antibiotics because we know if there is an element of ischemia, they can have bacterial translocation from the dead segment of the bowel. And like I said, an abdominal X-ray is rarely helpful. So get a CT scan with contrast. And you may be in a setting where you can do an arterial gas or a venous gas, and some gas analyzers will give you an EGFR as well at the same time. So that's quite important. If you're going down to radiology and say, actually, I want to get a CT scan, I've got this EGFR, rather than waiting for an hour and a half to get your renal function results back. So in an ischemic gut, I've got 2 scans, and both of them, I have to say, are extremes. But for learning purposes, those are the signs to look out for. On the left, you can see there is a segment of small bowel which looks quite prominent as compared to the rest of the bowel. It is thickened and it does not enhance very well, as you can see, as compared to the rest of the bowel. And that's one of the findings you will see if you suspect the patient has got a dead gut. To say the bowel wall does not enhance very well, it looks thickened, it looks sorry for itself. And on the right, you can see there is a bit of free gas. There is fluid around the liver, and the area, there are 2 arrows on that slide. One points out towards the free gas, and in the liver, you can see some gas locules, which are the dark black areas. And in a normal setting, you would not see this. But if you see something like this, you start worrying about the fact, has this patient got gas in the portal vein? And that is a bad sign. If the patient has got that on the CT scan, the chances of them surviving are minimal. So again, sort of ischemic bowel, the initial management, as long as you've done that, I'm sure none of this. Sorry? Yeah, I'm all right. So that's all you need. Obstruction is, again, one of the commonest causes what you come across. The patient may have colicky, abdominal pain, vomiting, distension, and constipation. But bear in mind, vomiting may not be an obvious feature all the time, particularly if they've got a competent ileocecal valve and the small bowel is not dilated. So I'll show you some plain films. On the left, you can see a loop of bowel, which looks like a large bowel, but you can't see any small bowel. On the right, it's a classical small bowel obstruction. And one of the common causes you see is whether they've had previous surgery and they've got adhesions, as a result of which they've got this. Have they got any masses? And make sure you check their hernial orifice. It's one of the commonest reasons why people develop small bowel obstruction. As a result of obstruction, they can become dehydrated and they can have electrolyte imbalance. And if there is a closed loop, i.e. to say there are 2 points of blockage within a segment of the bowel, the blood supply to that segment can get compromised. And that can develop ischemia and finally get perforated from that. So long as you know what these complications can be, what you try and do is to minimize them and prevent the patient from having any of those catastrophic events. So fluid resuscitate them. Make sure you've got an NG in, so that when they are anesthetized, they don't vomit and aspirate. They've got a catheter in, you've done an ECG, and you've done a CT scan. So on the CT scan, I'll show you a couple of pictures, and the arrows are just pointing out into the area which is the dark black area, and you can see there is air within the bowel wall, and that is a bad sign. When there is air in that segment of the bowel wall, you know that bowel is not healthy. It's probably ischemic by now. So perforations can be lots and lots of causes, the commonest one still being peptic ulcer that we come across. And on the left, it's a classical X-ray where you can see a thin sliver of free gas under the diaphragm. And if you see this, unless until the patient has had any recent operation or procedure, you know that this is a perforation. But bear in mind, you can be caught out by something called chyliditis sign, where the loop of the transverse colons gets between the diaphragm and the liver, which you can see on the right, and you can easily mistake that to say this patient has got pneumoperitoneum. But if the patient doesn't have signs and you think, well, actually the X-ray is not matching the clinical signs, the next thing to do would be a CT scan. So with perforation, again, give them analgesia, give them antibiotic, give them fluids, make sure you've started them on a PPI, get a catheter, ECG, and arrange for a CT scan. That's what we expect from A&E and nothing more than that. And lastly, I'm going to touch base on pancreatitis because that is one of the other reasons why patients get referred to general surgeons, and more often than not, they are quite tender. They may have signs of peritonitis or peritonism, and people may think, oh, well, actually they've got perforation. So you can diagnose them biochemically or radiologically. Biochemically, the most commonest test that's done is an amylase. So an amylase, which is more than 3 times the normal limit, will be a diagnostic of pancreatitis, provided the patient has got abdominal pain. But if the patient presents to you within a couple of hours, you may actually get a normal amylase, because we know that the amylase levels rises between 4 to 6 hours after the onset of pain and peaks at 48 hours. And by 5 to 7 days, it comes back to normal. So a couple of scans for you. On the right, I thought that was quite impressive, where you can see lots of stranding and fluid around the pancreas, which the arrows are pointing out. So if you see something like that on a CT scan, you know the patient has got pancreatitis, even if the amylase levels are normal. So pancreatics get fluid depleted very quickly. So aggressive fluid resuscitation is quite important. Do a gas, make sure, and in this particular one, I would say do an arterial gas, because they can be hypoxic as a complication of pancreatitis. They can go into ARDS, and you need your PO2 level to complete the Glasgow scoring for pancreatitis. So if anyone scores more than 3, you know they would need HDU care. And then finally start looking for etiology of pancreatitis. In the UK, gallstones and alcohol are the most common causes for pancreatitis. And then from then onwards, if you don't find that the patient has got gallstones or the alcohol intake is not an awful lot, you start looking for other things, i.e. medical causes. And one of them is hypercalcemia, which I'm sure my colleague is going to talk to you more about it. I'm happy to take questions at the end, and I'll finish my talk on this. Thank you.
Thank you very much, Sadaf. Excellent presentation. You managed to cover so many really important surgical acute abdomens that we see commonly see in the A&E. So I think excellent presentation. Very good. So next speaker is Dr. Fahad Wali Ahmed, who is a consultant endocrinologist here in England in Brighton hospitals. And he's going to talk about hypercalcemia and some thyroid emergencies.
Okay, Sadaf, I think you have to unshare first, and then I can start sharing. Yeah.
You should have it now.
Yeah. So, everyone, good morning, good afternoon, good evening. As everyone knows, I'm Fahad. I'm one of the consultants in Brighton and Sussex County Hospital. I'm going to talk about 3 topics. The first one is hypercalcemia. So hypercalcemia is quite common. In acute journal medical presentation is quite small. It ranges from 0.5 to 0.7%. But in population, it's quite high prevalence of around 3 patients per 1,000. It's more common in females than males, and usually most patients are usually above the age of 50. The most common cause is primary hyperparathyroidism. The other causes could include malignancy, which could be either ectopic parathyroid hormone production, it could be bone metastasis, or it could be activated vitamin D dependent, which is 125-hydroxy vitamin D dependent, like lymphoma. The other causes could include sarcoidosis, severe thyrotoxicosis, and in patients who are taking medications like bendoflumethiazide, indapamide, lithium, or activated vitamin D. And the rare cause is familial hypocalciuric hypercalcemia. Now, this is an autosomal condition which leads to a problem with calcium sensing mechanism. As a result, the patients have got benign hypercalcemia. So in these patients, we do not need to worry about the treatment of hypercalcemia. So the commonest presentation of these patients are usually in outpatient endocrine clinic, and they are usually asymptomatic, and it's just incidental finding of hypercalcemia. But in acute setting, these patients can present with classical symptoms like bones, stones, psychic moans, and abdominal groans. Usually by bones is basically bone pain. And if you see the picture on the top right-hand side, you can see this osteolytic lesion. So this is called osteitis fibrotica, basically. And these patients do present with bone pain. Stones, these patients can present with severe loin pain, like kidney stones. So our urologist usually sees these patients in the clinic and then refer the patients to us. Psychic moans could be neurological disorder like low mood, depression, in severe cases, even in mental agitation and coma. And abdominal groans could include nausea, vomiting, severe abdominal pains. Other symptoms could include like severe constipation, patients passing quite a lot of urine, and polydipsia. In severe cases, patients could also have arrhythmias like shortening of the QT interval, and in very rare cases, I've never seen this, which is the J wave, which is an Osborne wave. And very, very rarely patients can come in with VT arrest or VT arrhythmias. So if a patient presents, if they are noted to have high calcium, first of all, it's important to take a history, make sure they are not on medication which is causing hypercalcemia. And if that's not the reason, then measure PTH and vitamin D. Vitamin D will not help in the initial diagnosis, but it's always helpful to know what if the vitamin D is low for future management. But PTH will clinch the diagnosis. If the PTH is suppressed, then there are other reasons for hypercalcemia like malignancies or sarcoidosis. If the PTH is high or normal, then it's always important to send a 24-hour urine calcium and creatinine for us to do some measurements to see if the patients have got a benign condition like familial hypercalciuria or hyperparathyroidism. So in acute setting, I'm going to talk about acute hypercalcemia. So when do we need to admit these patients and treat? So if somebody presents to acute emergency unit or an A&E, and if the calcium is less than 3, these patients are usually asymptomatic. These patients can be discharged home without any treatment. If the patients have got a calcium of between 3 to 3.5, if they are symptomatic, then they need to be admitted and treated. But in most cases, we can discharge patients if the calcium is just above 3. And most of the patients usually present with a calcium of around 3.1, to between 3 to 3.1. And I think these patients can be discharged just by after giving a prompt IV fluid and then discharge home and then re-brought back the next day to the hospital for endocrine review in medical assessment unit. But if somebody presents with a calcium of 3.5, I think these patients should be admitted for prompt treatment. And the treatment strategy for me is very simple. Rehydrate, number 2. Is rehydrate again, and number 3, rehydrate. There's no point treating anything in the first 24 hours until we know it is due to malignancy or anything else. The second is to promote calciuresis. Third one is inhibit osteoclast activity, so kind of bone release from the bone, and then treat the underlying cause. So the fluid management in an adult who hasn't got any cardiovascular problem, the best to give 3 to 6 liters of normal saline over 24 hours. In elderly and patients with heart failure, this could be slowed down accordingly based on the fluid status of the patient. The second line is pamidronate. Now, I see quite a lot of junior doctors giving bisphosphonate like pamidronate. I usually do not advocate this to be given in the first 24 hours because it basically will make the diagnosis, making the diagnosis in the future difficult for up to 6 weeks. If we lower the calcium of patients by IV fluid by a few mLs, even by few mLs, basically 0.1 or 0.2, their symptoms will start improving. So there's no rush to reduce the calcium very, very quickly once we have given IV fluids. Usually what happens over the weekend, the junior doctors panic and they give pamidronate. And as a result, then endocrine clinicians will not be able to make the diagnosis because it will affect the calcium excretion from the kidneys. And as a result, we will not be able to measure the 24-hour urine calcium. And in my practice, what I have seen, that these patients will present again in 2 weeks' time with hypercalcemia and will be again readmitted for IV fluid treatment. And in those patients, then we are thinking, do we send them for emergency surgery or for something else? What should we do here? So it becomes a kind of a difficult situation that the patients are recurrently admitted for IV fluid up to 4 to 6 weeks. So it's better to hold fire. Once we have sent the 24-hour urine calcium and creatinine and we have checked from the lab that they have received it and they can process it, then in difficult situations, we can give pamidronate. And there are different dosing strategies. Patients with less than 3.4, we can give 60 milligrams. And if it's more than 3.4, we can give 90 milligrams. And the second thing is just to hold fire after that. Pamidronate will not work immediately in the first 24 hours. It will take up to 72 hours, 48 to 72 hours for it to work. And it may take up to 5 days. And it can last up to 3 weeks. I've never used calcitonin because if you have given IV fluids, usually most patients do recover, and I think the second line I'll use bisphosphonate. But if we cannot give bisphosphonate, we can use calcitonin. And it has got rapid onset of action, and it decreases calcium by 0.3 by 2.5 mmols per liter. But it can be used once or twice, the reason being that the patient will develop tachyphylaxis at 48 hours. In literature, people have used denosumab. This is again an anti-osteoporosis treatment, which is commonly used these days. But in my practice, I haven't used denosumab. Cinacalcet is used by the renal physicians quite a lot for tertiary hyperparathyroidism. There is no role of cinacalcet in acute hypercalcemia, but patients who we are unable to treat for primary hyperparathyroidism, or patients who have got renal failure on dialysis and have got hypercalcemia, we can then use cinacalcet in those patients. But if the patient can undergo hyperparathyroidectomy, then cinacalcet should not be used according to the guidelines. Though in some cases we do use it just as a bridging mechanism to prevent readmissions so that they can have surgery. Steroids can be used. The reason of using steroids is it stops the production of activated vitamin D, and it's usually used in patients with lymphoma and sarcoidosis. Things to avoid if possible. We can use, I've once only used furosemide in patients just to increase calcium excretion, but the problem is that patients with hypercalcemia usually presents with dehydration, and by using furosemide, we can actually worsen it. 20 milligrams IV is a small dose. But in patients with a normal kidney function and a fluid status where they are not dehydrated, it will help. If we have used bisphosphonate, then we should hold fire, and we should not repeat giving a bisphosphonate for up to a week. We can repeat it after 1 week. And bisphosphonates usually are used in patients with malignancies. So if we know that malignancy is the reason, and we've got a diagnosis that this is due to malignancies, then bisphosphonates should be used. So the common pitfall of the treatment is inadequate rehydration. In patients with bisphosphonate, first in using it at for the first time, and then reusing it again within 5 days. The third one is incorrect diagnosis. So it's quite common for patients to be diagnosed with primary hyperparathyroidism, and then in outpatients clinic, we are basically sending patients to respiratory clinic for treatment of sarcoidosis. And the last one is not proceeding to definitive or second line treatment if the first line hasn't worked, so which includes emergency parathyroidectomy. So in patients that we kind of delay the treatment, and then as a result, the patients develop more complications with regards to extended ITU admissions for hypercalcemia. But it happens quite rarely. The second topic is thyroid storm. So the thyroid storm is a very rare presentation. I have never seen anybody present with thyroid storm so far in my career. They have presented with impending thyroid storm, but not in thyroid storm. This is usually a life-threatening condition with a high mortality of around 20 to 30%. It's usually triggered by an infection on the background of a severe long-standing thyrotoxicosis. Now, it becomes very difficult if somebody comes in with a low GCS and completely moribund in accident emergency, then is it thyrotoxicosis or thyroid storm, or is it just sepsis-driven deterioration of the patient? Thyroid storm can also present after thyroid surgery. So patients who have got Graves' disease and they had thyroid surgery without appropriate beta blocker, they can go into thyroid storm. Patients who have undergone radioiodine treatment for thyrotoxicosis without appropriate euthyroid status, they can go into thyroid storm. Patients who have had CD contrast scans. So I see quite a lot of patients presenting to A&E with thyrotoxicosis after a contrast CT. So they first get admitted for probable abdominal or kind of a surgical problem. They get a CT scan. they are discharged home because they don't have a surgical problem, and then they represent within few days with thyrotoxicosis in medical assessment unit. So thyroidostorm is diagnosed by using a Birch-Wodsky criteria, which is BWPS score. It's very rarely used. Basically, we look at temperature, central nervous system effect, gastrointestinal dysfunction, cardiovascular dysfunction, congestive heart failure, or heart arrhythmias like atrial fibrillation, and other precipitating events. So if the total score is less than 25, patients do not have thyroidostorm. Patient presenting with the score of 25 to 45, they are en route to becoming or developing thyroidostorm, but they haven't got thyroidostorm. And almost all of the patients I've seen are in this area. And they could be in this area because they've got sepsis, so they are slightly hypotensive, they are tachycardic, or they have got atrial fibrillation because of sepsis, is sepsis driven. But it becomes very difficult to differentiate between the two. I've never seen anybody present with a kind of bondo thyroidostorm or with a score of more than 45. So for general physicians, I think the management is to give IV fluids, send appropriate investigations like thyroid function, UNEs, full blood count, LFTs, calcium, glucose, do an appropriate septic screen, and also do an ECG. I think the best option for these patients, if you suspect that this is thyroidostorm, is to contact ITU out of hours, and during working hours to contact endocrine department and then HDU. For the
you have 5 minutes.
5 minutes. For the endocrine person, the treatment approach is either by controlling symptoms and signs of increased androgenic tone, block new hormone synthesis, block the release of thyroid hormone, inhibit conversion of T4 to T3, and decrease thyroid hormone reabsorption. So the beta propranolol is given in these patients, either oral or IV. Propylthiouracil, oral or NG tube. If the patient is unable to take medications orally, then propylthiouracil is given, and that's the first line in United Kingdom. In America and I think in Japan, I think methimazole is more commonly used. In these patients, I will give IV hydrocortisone. The reason being is that it stops the conversion of T4 into T3. If we are going to sedate the patient in emergency, then chlorpromazine is also given. In very rare cases, we can give cholestyramine, and cholestyramine will stop the absorption of thyroxine from the gut. So basically, we're trying to reduce the recycling of the thyroid hormone. And after 60 minutes after giving propylthiouracil, we will give legolidine. The reason we do that, because legolidine will be used, if we give it before propylthiouracil, legolidine will be used by the thyroid cells to produce thyroxine. And as a result, the patient thyroidostorm will get worse. So once we have given propylthiouracil, it will stop the production of thyroid hormone, and then we can give legolidine, which will again basically will work together to basically stop the thyroid hormone production after the administration of legolidine. The last topic, very briefly, is mixed edema coma. Again, very rare. Is defined as severe hypothyroidism leading to decreased mental status and multi-organ failure. The mortality rate is extremely high, 30 to 50%. Again, very, very rare, and is usually precipitated in patients who have got a diagnosis of hypothyroidism and not taking their thyroxine and presenting with acute event like illness like myocardial infarction, severe sepsis. They usually present with hypothermia, decreased mental status, hyponatremia, hypoglycemia, hyperventilation, bradycardia, and elevated CK levels. Again, the management is give IV fluids, send appropriate investigations like thyroid function test, look for infections like doing chest X-rays, cultures. I think the most important is to do a cortisol level. I think that's the key in patients with mixed edema coma, that we want to make sure that we pick up patients with adrenal insufficiency at the same time. Because if they've got autoimmune hypothyroidism, they're more likely to have autoimmune adrenal insufficiencies as well. Always important to do an ECG, and in out of hours, refer the patient to HDU. So the treatment option is to give thyroid hormone, give IV hydrocortisone, again give supportive treatment with IV fluids, and treatment of coexisting condition. So we'll give IV hydrocortisone in everybody till we exclude that they haven't got adrenal insufficiencies. Now, The second line with regards to thyroid hormone treatment, now this is quite controversial. Everybody does it differently, and I think it's better that it's discussed with an endocrine physician before giving any thyroid hormone replacement. In UK, mostly some patients get T3 either oral NG or via IV, and then after a few days they are giving levothyroxine. I usually don't like doing that. If I ever get a patient with mixed edemocoma, I probably will start with levothyroxine first, which makes it extremely difficult because it's not a common condition we face. And again, there's quite a lot of controversies. How do we manage these patients? There are no randomized controlled trials to see which treatment is better. Both treatments are fraught with problems. If you give T3, the patients can develop cardiac arrhythmias very, very quickly. If you give T4, then we are not treating them appropriately because it takes few hours or sometimes up to a few days for the levothyroxine to work. Do we give it IV? Do we give it oral? IV is not available that easily. Oral sometimes doesn't work because of GI malabsorption or delayed GI absorption. So it's quite difficult to manage these patients. But these patients should be managed in intensive care. And depending on that, I think, depending on the preference of treatment by the hospital, then the treatment plan should be started accordingly. And I think that's basically it. Thank you very much.
Thank you very much, Fahad. Excellent presentation. Excellent talk. I certainly learned some new things today. Okay, so we are going to open the forum for questions. If anyone has got any questions for Sadaf, acute abdomen or thyroid or endocrine emergencies. So any questions?
I think all the presentations were really amazing and excellent, and they were very descriptive. So I think we learned a lot today. Thank you, both of you guys. Excellent.
Welcome.
So, Sadaf, I just wanted to ask one quick question about abdominal, this aneurysm, leaking aneurysm. So, is there such a thing like as a chronic leaking aneurysm, or is it always like all or none? So you leak or you don't leak, or you just leak and die, or is there such a thing as leaking going on for a few days?
There is something called a contained rupture. I don't know whether you're sort of referring to that, which means that the rupture has happened, probably not in the last few hours or so, but
Right.
it must have happened probably a day or two ago, but it all still contained. So within the retroperitoneum, you can see probably the wall of the aneurysm has given way somewhere, and all it has got is a bit of a clot around the aneurysm itself. But as we saw on the CT slide that I showed you, you could see lots of blood in the retroperitoneum and around the aorta. It's not like that. So what you can see is there is a breach in the wall of the aneurysm, and there's a bit of a hematoma around it, which you call, in other words, like a contained rupture. And those are, again, so patients, they come in with pain, but they're not really unwell with it. And those are the patients, probably the ones that I have seen, they've got like big aneurysms, and some of it has given way because of the pressure. But that's the ones that you call as a contained rupture. And
Right.
still, those are the ones that you would still operate on them as a matter of emergency.
Right. Okay. Thank you.
Fahad, can I ask you a question, please?
Yeah, you can, yes.
You mentioned about bisphosphonates as part of treatment for hypercalcemia. Now, I know in certain cancers, bisphosphonates are given as part of treatment for the cancers.
Yes.
And denosumab, certainly in breast cancer, it's licensed now and recommended by NICE as well, that you should give them as part of the treatment in the adjuvant setting. And I just wondered, is that something that if you start your patient on denosumab, would you recommend the clinicians to keep an eye on the calcium levels?
Definitely. I think especially after the initial start, I think they should have a calcium level check because I think this is given every 6 monthly. So definitely in the first 2 weeks to recheck the calcium levels is extremely important, yes. Denosumab usually is given in patients with the risk of, I think, to prevent bone metastasis. So if there is a, if there's a drop in bone density, the patients are usually given denosumab in cancer setting, and definitely in breast cancer, I think, is to prevent bone metastasis.
That's right, because there is something to say it improves the survival as
Survival,
well.
yeah.
So there's more and more use of denosumab for breast cancer patients.
Okay.
And again, sort of, if you were to check their calcium levels, how often would you do it?
I think I would check it in the first 2 weeks, and I think then every 3 monthly. I think that should be fine. And I think we should also always warn patients with regards to symptoms of hypocalcemia. I would do it every 3 monthly after that, and I think depending on the patient's symptoms.
Right, thank you.
Okay. Any other questions from anybody?
Oh, so they've actually asked my question, but that's good. We were both thinking on the same wavelength. Just a last reminder, guys. You all know that me and Sadaf are contesting for the executive seat. Please, we all both need your support, and it's right around the corner. And if you want your batchmates to win, please vote for me and Sadaf. That's all. And thank you again, guys, for a wonderful, wonderful teaching session.
Thanks, Wade. Father, just a very quick question about the thyroid replacement. You mentioned about T3, T4, and just tell us general physicians, I mean, what's the difference? I mean, if you are replacing IV, T3 first, T4 first, or both good, or I mean, what's the difference?
I think T4 is slightly slower acting. T3 is more potent. It's basically most of our thyroid function. T4 is converted into T3 for it to function, and it's quite potent. And if we give T3, I think the risk is always with regards to cardiac problems. So patients developing arrhythmias, heart failure. So I usually will not recommend giving T3 in acute setting unless it's done in HDU with an endocrine physician present. T3 is very difficult to find these days. It's extremely expensive. Most of the CCGs and the trust have not basically, they are not even available in the hospital. So even if I prescribe T3 here, it may take up to 48 hours for me to get it. I have to go through multiple hoops to get it. So it's not available in every place. Patients have to, if they are taking it from outside, they are taking it privately. They're buying it from outside the country sometime because in UK it's extremely expensive. I think a month's supply is around £360. So the CCGs have stopped using it. So in acute setting in the first 12 hours, I think let's say somebody comes in at overnight, I think it's better not to use it in my view. Unless there is a clear, I think if you have contact with the endocrine physician and the patient is HDU and T3 is available, then a very small dose can be given as a first trial dose. But I wouldn't give it routinely.
Right, okay. Thank you.
Fahd, one more question on this. Sure. Why would you prefer T3 over T4?
I wouldn't prefer T3 over, I said I will prefer T4 over T3 because T4 is much more slower acting. It's less potent. So there's a less likely chance of patients going into heart failure or cardiac problems.
And T4 will be converted into T3 in the body, is that right?
It will be converted, but it will happen slowly. It will happen slowly.
If it happens slowly, that means you have more control over it, isn't it?
More control over it. So, I mean, as I said, I've never seen anybody presenting with mixed edema coma. It's very, very rare in Western world. It can happen. I think we've had patients who have presented quite unwell with severe sepsis, and they were much more unwell than they should be for regards to their sepsis. It's just because they were not taking thyroxine, and just by replacing levothyroxine, they got better. So there is usually no need to give T3 unless the patients are basically presenting with a low GCS, very hypertensive, and I think no other treatment seems to be working, then we can consider giving T3. But I would start with T4 first, and if they are not improving, then to add T3. I think the problem is that we don't see it that often. There is no randomized trial, so everything is observational. And it depends on the clinician's preference what we should use. But I will start with levothyroxine. If somebody is young without any heart problems, I'll start with 50 and then increase the dose accordingly. And I can repeat it again and again. If they are not improving, then I will add T3. But again, some hospital guidelines say start with T3 and then give T4. American guidelines, again, quite variable. So every guideline is quite different from each other.
Okay. All right. Well, Fahd, one last question. We do that a lot in our surgical setup, that if we see somebody with hypercalcemia, I know our juniors over the weekend are going to give them pemidronate. So what is, in your experience, I know you said give them IV fluids, rehydrate. Fine. But at what level should we intervene, or should we not intervene at all? Or should we just get our endocrinologist to come and review, or pass it on to the medical team to manage the patient from there onwards? At what level do we actually call the medical team?
So I think if somebody's calcium is above 3.5, definitely call medical team.
Yeah.
If somebody's calcium is above 3 and they are severely symptomatic, then yes, call medical team. Usually, if somebody is symptomatic, giving IV fluids will work, should work in most cases. I think they are just dehydrated. You just need to fill them up with the fluids. If we lower the calcium just even slightly by 0.2 mmols, their symptoms will start improving. So there is no rush to give pemidronate in my view, especially in the first 24 hours. I think if we can send the 24-hour urine calcium creatinine, then it will be helpful. If we can't, then it becomes difficult. Then we can't. There's no point sending a 24-hour urine calcium creatinine after pemidronate because it will affect the calcium excretion. Usually, IV fluid should work, and I think after 24 hours or 48 hours, if it's not improving, then to give pemidronate, that will be fine. But if a patient has got malignancy and it's very clear this is because of malignancy, then pemidronate can be used, because the patient with malignancy will present with a calcium of 4.5 even above that.
Yeah.
So in those cases, you know that this is clear-cut malignancy, this is bone mets, or malignancy driven, then the pemidronate in that case can be given.
Awesome.
Thank you. Sadaf, I've just got one last question for you. With the amylase, now we see this, I certainly see this all the time on acute medical unit ward rounds and patients coming in with abdominal pain. And if the amylase is like 5,000, then we have got a diagnosis. But most of the time we see these patients with amylase of 200, 350, 450, 150, and they have got some abdominal pain. And we know that amylase is not very specific. So it's a sensitive test, but not very specific test, if I'm not wrong. And then it goes up in other conditions and with bowel ischemia and even in non-abdominal conditions like mumps or whatever. So what is the guideline on this? Can you diagnose just on the basis of amylase? If it's certain number or above and just start the treatment, or do you need to have a CT or some MRI or something more definite test to actually look at the pancreas and see what's going on? Or can you not make this without imaging, just on the basis of the borderline amylase score?
Sadaf, your voice.
Hang on. So if you're, yeah, we can hear you now. Yes. Okay.
So, a high amylase, that's clear cut. That's Mandor pancreatitis and amylase of 800 or 900. Anyone would buy that. You don't need to do a CT scan in those situations.
Yeah.
Now, and we do get that very often, alcoholics coming to a medical board due to lots of reasons, and someone has done an amylase and the amylase has come back as 240.
Exactly.
Okay? Exactly. Which sort of puts you into the dilemma, is it pancreatitis? Should I treat it as pancreatitis or should I not? Now, there are a couple of things. If this patient got abdominal pain in the first instance, that's one thing. Because even if the patient doesn't have abdominal pain, then doing an amylase is of no value. If the patient has got abdominal pain and the amylase comes back as 240, then it goes back as to how long the symptoms have been going on. Is it a very short history, or have they had pain for like 7-10 days? Which means, it must have peaked, and now that we are catching it when it's on its way down.
Right.
But if you think the patient is still within that time limit where you would find a high amylase if it is pancreatitis. Now, it could well be that if this patient has had previous pancreatitis, so, you see lots of chronic pancreatitis. If they've had previous episodes of pancreatitis, which means the pancreas has already been burnt out and there's not much pancreas left to generate that amylase, they can still have pancreatitis, but it's just that it's not reflecting biochemically. So in those cases, to prove that this is pancreatitis or not pancreatitis, you need a CT scan. And likewise, you know, if the amylase level comes back as in one of the gray areas, then you need a CT scan, because if the patient has got pancreatitis, you got to treat it the way it is. But bearing in mind, there could be lots of other acute surgical pathologies which can give a high amylase, but it doesn't necessarily mean that the patient has got pancreatitis.
Sure. Okay. So CT is definitely, so ultrasound sometimes people do to look for gallstones and all that. I mean, I think they are just looking for the etiology of pancreatitis and not the
That's
pancreas.
right. So once you've proven the patient has got pancreatitis, then you do an ultrasound scan to see that has the patient got gallstones or not. And that comes sort of after that. Your other question was, do we need to do an MRI scan? If you're checking for pancreatitis in an acute setting, a CT with contrast is the best test.
Okay.
But then if you've got someone who's got pancreatitis, ultrasound is normal, they don't drink, the biochemistry, rest of the things have all come back okay, then you start looking for any anatomical abnormalities, you know, i.e. have they got pancreatic divisum? So then you do start doing an MRI scan, or you think the history is quite suggestive of gallstones and you can't really prove that on an ultrasound scan. So MRI is right, taking it a step forward to look into it, the etiology into much more detail if there is any.
Right. Okay. Excellent. Excellent.
Okay.
Anyone else got any more questions?
I will add one more thing regarding denosumab. I think it's always important to check the calcium and kidney function before starting denosumab, and that needs to be reviewed by the physician or the surgeon, whoever is prescribing denosumab, before giving denosumab, and then repeating it kind of at 2 weeks, and then thereafter, depending on the symptoms, or kind of at routine 3-monthly points.
Okay. Thank you.
Yeah. Thank you. Okay. I think this is excellent. So I'm just going to wrap up the session. Thank you very much. Excellent speakers. The next the next session is, as you can see on my screen, is the next month on the 3rd of March. And it's cardiology for non-cardiologists by Dr. Yawar and Saqib Ghani. And it's on the 3rd of March. So I've already shared the link, and we'll share it once again nearer the time. We just recorded the session, so it will be available on cloud for you to watch later, or people who were unable to join. Send me your full name and your email address to my email, naseemnaqvi@me.com, and we'll send you the certificates. So thank you very much, everyone, for joining, and have a nice day, and chat to all of you soon.
Thank you, Naseem.
And thank you, Naseem.
Thank you, everyone.
Thank you all, both of you, Sadaf and Fahad. Thanks a lot, guys.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Okay, bye-bye.